Welcome to the Grand Round. We've got a few people here face to face and hopefully lots of people online. So I'm Nick Maynard, I'm one of the upper GI surgeons in Oxford, and it gives me great pleasure to introduce a great friend of mine, Professor George Hanna, who is going to be speaking at the Grand Round today. George trained in Dundee under Professor Sir Alfred Kosheri, and then moved to Imperial College as senior lecturer, and then became the Professor of Surgical Sciences there in 2008. He became head of the Division of Surgery in 2012 and head of the Department of Surgery and Cancer in 2018. He heads a huge research program, but he remains also a very busy practicing esophagogastric surgeon and recognized as one of the leading esophagogastric surgeons for cancer worldwide. His laboratory research revolves around volatile organic compound analysis for biomarker discovery and understanding their mechanistic drivers to help develop a breath test platform to detect multiple gastrointestinal cancers. George, thank you very much for coming. And George is going to talk to us about breath tests to detect GI cancers. Thank you, George.
Thank you very much, Nick, for kind words and for the invitation. Very much appreciated. So just one slide about background. So GI cancer really is very global, the global burden. And a very big number of people really suffer from GI cancer and die from GI cancer. The key point, if you look at GI cancer, is about really 20% of all cancers and very similar number of mortality really because of the cancer. So it's a global burden. The key point is an overall early cancer have a better survival. So this is early cancer, has a better survival than overall, and definitely better survival than later stage. Now, symptoms of GI cancer are shared with benign disease. And this is why there's a delay in diagnosis, and with delayed diagnosis, poor survival rate. And this creates a balanced dilemma, which is if we wait and see for people with non-specific symptoms, then we'll miss cancer and will be late diagnosis. If we did an early referral, then will result in unnecessary investigation. So it'll be always a balance, whether to refer early or to wait and see. And each one has a consequence. The solution I'm going to talk about today is whether a trash test will help this balance. So if we do a test, if it is positive, then we refer for investigation. If it is negative, we reassure. Very similar what is the FIT test really currently happen with colorectal cancer. Breath test is non-invasive and highly acceptable. That's no doubt about it. I'll show you some data about this. And one of the key things about breath is detect volatile compound. And this happens at an early stage of the disease, not just at a later stage. So if you're going to depend, for instance, on a DNA shedding in a blood, it doesn't happen so early. But for VOC, it happens early change because the signal is not only from the cancer, but it happened from the response to cancer and microbiome associated from cancer. And that's why sometimes the signal would be early. So this is not a new thing. In 1971, Linus Pauling found volatile compound and by GCMS, and he's a double Nobel Prize winner. And the volatile compound defined as carbon-containing compound, which are volatile in the gas phase as room temperature. So that is really, so basically these are compounds at a normal temperature in the gas phase. It is commonly used for detection. You know, you get stories about dogs smelling different things in the rescue. Food industry really is well established, actually. And clinically, H. pylori, small bowel bacteria overgrowth, nitrous oxide with asthma. So there are really precedents which happen in day-to-day life and clinically. Just tell you what the system we have. So we looked at few systems, but that's what we currently have. Patient breathe in a bag, takes half a minute, and using a pump with certain rate and controls, move the compound into a solvent inside stainless steel tubes. And when we have a system which allows us to keep the compound with no loss for about 3 months. And then goes to the lab and mass spec analysis. So from a patient perspective, is breathing in a bag. And this is an attraction. Of course, there is different, we looked at the material of the bag, so a lot of things to control it, but from all the burden lies on the analytical part, it doesn't lie on the patient. So all of the patient need to do is breathe in a bag. So we have done few studies. I'll just give you some background. So done initially a study which we have done at St. Mary very early, which showed very reasonable results. And then this is an external validation study which happened few hospitals in London. This is what Shiraz did, which shows the signal stands. So we've been encouraged more. And then another PhD student did the tube, which I showed you, make it really a bit more sustainable at a larger scale. And actually, because in the tube, we can concentrate the amount of the volatile. So even we get a bigger signal. So that was encouraging. And then we said, well, if GI cancer does stay for other type of cancer. So we did a colorectal study, which still have reasonable accuracy, with about 90%. And what we found actually is the markers for colorectal were different from the upper GI cancer. And then we did the same again with liver, which showed again encouraging results, and with pancreatic cancer. So those are proof of principle studies, and we've done them in sequence because the key question really in our mind is to have a single test for each cancer is a GP practice, not practical, because the GP will not have one test for every condition, just will not work. So the idea whether we can have a platform technology. So we've done a series of pilot study in numbers around the hundreds to see if there is something we can take forward. And secondly, can we have a platform rather than a single test for a single disease? But the key question really is always, do we really know where the compound coming from? Or is it a black box come up with compound, and can we validate this or not? This is the key question really, which will get biological validity and they give the confidence of the scientific society. So we looked at we extracted lipids from different cell lines, and we found it different, and the volatile are different between different cancers. So even at a cell level, we found a significance. So what we found in the clinical study was supported by a lab work. So the signal are different between different cell type. And when we looked at lipids producing volatile, we find really a clear transition from the origin of the volatile from the lipids. So we can hear certain lipids and exactly where is the double bond and where is the volatile coming from them. So what does this mean to us? That lipids produce volatile, and different lipids from different cancer produce different volatile. And this was in a cell work. So this means that the clinical data have some really something to support at a cell level, but still all this is a pilot data. The question really is, if we take one cancer, where is how can what is happening? Why do we get this cancer? Just give an example esophageal cancer. So the lipids, when we compare the lipids of esophageal cancer with patient and controls, we found the lipids of esophageal cancer are longer. If you look here, these are longer lipids. So if here the cancer is red, is longer and more desaturated. And because they are longer and desaturated, they are oxidized easily to produce volatile aldehydes. So the nature of the lipids of esophageal cancer are more prone to produce those volatile compounds. And the other thing is, it's not only a production, the detoxification of aldehydes is reduced because the enzymes and genes which will degrade those aldehydes are downregulated. So actually, it's not only having a production, but having the clearance of them is reduced. And that's why the volatile increase in cancer. This build up as well has to be released and released to the volatile. And what we found a correlation between the tissue aldehyde and the volatile aldehyde. So if we take this and account, so there's increased production, there is reduced clearance, and that's why they come in the breath. But the question really, what influences this? So working with Professor Preston in Manchester, we looked at the tumor hypoxia, whether this increases as well the aldehydes. So we did we looked at the phospholipids, and we found that phosphoethylamine and phosphatidylcholine are increased under hypoxia. And what we found as well is the reactive oxygen species are increased, and antioxidants reduce them. So the hypoxia increase the volatile in esophageal cancer. And when we stain them, those reactive species will cause lipid peroxidation. The green here, this is normal oxygenation, and this is severe hypoxia. If you look at the green dye, which is a body pie dye, you'll find more with hypoxia than a 20% oxygen. So the oxygen species increase the aldehyde, the peroxidation. And severe hypoxia increase more the aldehyde. So if you look at here, different level of hypoxia, you feel the severe hypoxia increase the aldehydes. So what this means for us is there's increased production because of the phospholipids. There is decreased clearance, and tumor which hypoxic increase even more the aldehydes. And so those stains, those are slides, I got them from Ewan Griffiths, and when he did his PhD in Manchester before he went to Birmingham. And if we stain the tumor with the pimdazepole, you can see here the tumor hypoxia. But so we know that the tumor is hypoxic. And what we have done is we created, one of the PhD student, Bebek, created a gene signature for esophageal cancer from the literature, and then validated with Occam's data, and found that aldehydes increase when there is hypoxia at a tumor level. And what he's doing now, getting the volatile, staining getting the tumor hypoxia area stained, and then doing spatial lipidomics and transcriptomics, and then exactly knowing why the tumor hypoxia produce, what is the pathway tumor hypoxia produce aldehydes. So what I'm just trying to say that for esophageal cancer, we can follow the compound, we know where they are coming from. The question really is, they don't only come, the volatile don't only come from the tumor, but they come from the microbiome associated with the tumor. Because the microbiome change happens, and actually it happens early, which actually is very good for diagnostic, because we can use the microbiome associated with cancer to help us to pick it up earlier, because T1 disease is a very small tumor volume, what we need to do, use the environment to produce the volatile. Actually, bacteria produce a lot of volatile. That's what they do in industry. So we done a literature search. One of the PhD, Bemini, did a literature search, and we found what is the microbiome coming from cancer. And then we did our study to confirm this. We did a profiling study because we needed to culture the microbiome. So we take tumors, we separated the microbiome, we cultured the microbiome, and we did the 16S and the metagenomics. And we found people, again, that's an example, people with cancer having more than non-cancer. But the key point here is, it's not only in the gastrointestinal, in even the saliva, which is very near, the microbiome changes. So if we have a change happened in the GI tract and early stage, the key question really, can we even use it to produce, to help the signature?
Professor of esophageal gastric surgery.
The key question for us, like, if you look at diabetes, people do a fasting blood sugar, and then they get people to eat, and then do blood sugar again. So what we thought, can we really feed the microbiome and use the microbiome, which it changed, to even get a bigger signal for cancer, especially in the early stage? So just give an example, can we augment really the signal? So almost people get the folded change will be a bit more powerful than an absolute number. So we did again, so we get the bacteria which separated from the patient, we give them glucose, and you can find the folded change and just get our compounds. We did with a 2-dimension, single dimension TD, we did all the analytical part. So actually, we can use the bacteria now as in our favor. And what we have done, we did, not me, Bemini did a lot of studies and get the microbiome, get the volatile, and then this is a Sankey pathway mapping to know what are the pathway in the bacteria, and then give them specific compound, glucose or glycerol, and we can see here that the VOC increases, like sometimes it increases early, like this green line, for instance, gastric cancer, the red line, esophageal cancer, or can continue to increase over time. So this means that the microbiome associated with the bacteria could be a source for diagnosis. Now, the key question really now, how to marry the clinical study and the academic study, the clinical study and the lab work. One, there are two strategies here. One, we can use the biology to confirm the breath biomarker. Just give you an example. Here, we spoke about the aldehydes. We can correlate the tissue aldehyde with the breath aldehyde, like a decanal. But sometimes we don't find the compound in the tissue. If we don't find the compound in the tissue, we look at the microbiome, we look at branch-changing fatty acids. So we'll know exactly the source. Is it the tumor? It's the microbiome. So when we have in the model, we know the source in the model. But the second strategy is to use it to really look specifically for certain compound in the breast. This is Stefan did here, you know Stefan well. Stefan did this work. So he looked at aldehydes in the tissue. We find a group of aldehydes with a very high difference between cancer and no cancer. So what we have done is we said, fine, we know those aldehydes present in the tumor. Can we find them in the breath? Then we adapted the method in the mass spec, and we can find those compounds with a 1.5 part per trillion. So we really can find them in the breath. So we use the data from the tissue to refine the breath analysis method to find it. But being a surgeon, so we say, well, where do they come from? So we get the breath, like at the beginning, and then we get air from the airway, and we get air from the stomach, from the tumor during endoscopy. So we really know exactly where they're coming from. We know they're coming from the tissue, when they come from the tumor, we know whether bacteria, we know whether cancer too. And this gives us really optimal analytic and some biological really where coming from. Now, the question really now, can we do this in a more systematic way? And this is what we're doing in multiple cancers. Collecting the breath, the tissue, aspirate and biofluids, having a biobank of the organoids, immune cells, and microbiome from the tissue, aspirate and saliva. Grow the organoid, grow the microbiome. Organoid, we have a system developed for that, and microbiome in a bioreactor, and they change the conditions. And know the volatile which is coming from each one separately, and then co-culture them together, and to know when we co-culture them, what happened. And in the same time, doing the multi-omic analysis, and do pathway analysis. Pathway analysis, we use different techniques, signaling pathway and neural network and fusion techniques, and tell us where is the pathway, how the interaction between the organoids, the microbiome, immune, produce the volatile. And then confirm this in functional study and with isotope labeling. Then we know exactly where are the compound coming from, and then we have the mechanism to augment them. Either give them compound, different ways. So the augmentation actually is like the diabetes is wonderful because it will allow us really to have patient almost like their own control. And you are continuing using the lipids because we know that the lipids produce volatile. So this is the foundation program for the VOC. But the key question really here is, can we validate this? Because you can have a diagnostic data with biomarker, but the key question really is, can this stand a validation study? So currently we're having 3 big studies going to optimize the model. We have a model, just make sure the model stands in another cohort of studies called the narrow validation, the multi-center study. For esophageal and gastric cancer, pancreatic and colorectal cancer, with a reasonable number of patients, around 700 in each group. And then next year, we're going to do a triple-blind validation study. And for the validation study, the patient, because those patients without knowing diagnosis, patient coming, collecting the samples, analyzing the VOC, classifying cancer, all those people don't know that whether the patient has cancer or not. So all the triple-blind validation study, nobody knows what the cancer. Only one knows is the statistician who really opening the code at the end. And is around more than 20,000 patients in those 3 cancers. And this will give us really confidence whether really it is a valid test. So because this will mean that is a validation study, is a blind study, is a multiple cancers. At the same time, in parallel to this, we're knowing where the markers coming from. There are 2 subgroups of patients who are like we can't do in big studies because they are just not common, which is a T1 disease because T1 disease, to get them in 7,000 patients, you get small numbers. So we target those patients in lists for the Barrett's and to resect T1 and the high-grade dysplasia. Very defined study just to do this one, to see whether we can pick it early or not. And actually, we're now doing the validation study, actually, to be honest, exceeded our expectation to the degree that we've not published it because I said, well, that can be really, it's too good to be true. Let's just wait to validate it rather than publish a study with internal validation. I said, well, let's just wait, do the external validation blind because we do this one. And the other one is the esophageal cancer one, which one of your registrars did, and me as well. So, which is really because esophageal cancer is very uncommon. So we did a study, and we supplemented this study with overseas centers. So this is the current study. We doing one in liver, but not so developed, so that it's included. But those are the ones which really allow us to know with reasonable confidence that whether we have a truly diagnostic or not. To do, if you put everything in the lab, we are now almost over the next 4 years, we'll be doing around 30,000 patients, pretty big number. So we have to change what to do in the lab. So we automated everything really now, a lot of things automated. So we have multiple units, like cleaning the tube. We can get 80 tube every 3 hours, clear. We got a robot and modify the system and around it so we can put the internal standard in those tubes without reducing the errors. Because if somebody going to do 300 tubes, we can't do this every day, although a few people will do this. So we automated this too. And then each instrument can take thermal absorption about 100 tube, and we have 9 replica instruments, just exactly the same instrument. So, and we separated the lab into a clinical lab and experimental lab. Clinical lab has a different criteria. I'm going to talk about it. So the key question really at the end, which I spoke about at the beginning, can we have a platform technology and a test, or are we going to have a test for each cancer? So from analytical perspective, the trial design allow integration of data because done in the same time, same equipment in the same team. The volatile are specific to the cancer type, and there's a lot of data to support this, which we have to. It's a single breast collection and multiple cancer by the same equipment. It's like to do a blood, the analogy is you do a blood test and you take some bloods and you can look for the kidney and the liver and a few other things. Exactly the same. The idea is single test, collection, same instrument, looking at different markers, different algorithms. This is the analogy. From a clinical perspective, it makes sense too, because when people have non-specific symptoms, we don't know whether it is esophageal or a gastric, or like if non-specific abdominal pain can be few things. So from a clinical pathway, it makes sense to group them together. And if this true, if the results are true, then that's kind of changes the pathway, because how to handle it will be in a different way. A key thing is really acceptability. So we have done a study to see whether we can recruit in primary care, and this is a colorectal study. And so it's more than 2,000 patients, and 99% showed this is easy because you are breathing and so it's easy. I don't think it's a surprise, but sometimes you need to quantify. Unless somebody really has a breathing difficulty, they can breathe in a man. The question really as well, do we do things in parallel, or do we do things in sequence to get into clinical practice? So we have a different views. I adapted a very different view. The analytical people in the lab recruited them from industry, because 30,000 patients, you can't just do this with a postdoc. You know what I mean? Would like to write the paper. You just need people who really do it with accuracy. Did a human factor studies to know where to put it in, and like all stakeholders really almost agree, it need to be as a trash just in primary care, whether to get it at the beginning and then you go for endoscopy or a CT scan, whatever. Did some economic modeling to see if it is successful, will it work in the NHS, allowing for, actually didn't use the number we have, we used a lower accuracy and allowing for more people to do the test, because if you have a breath test, more people will examine, more people negative and positive, false positive, negative. So we did all this, and for upper GI pathway, it would be really, for an NHS perspective, that would be really, and so we did this at Imperial, and then I said, well, that's 2 good numbers. Let's just get an independent consultant, economic modeling company to do it, and they come up actually with a better number. So it makes a big difference actually, and we needed this for fighting the programs, etc., just to show that this is the real value in the future, if it works, of course, because we need to wait. Then to allow us to do it without repeating the studies, getting the lab ISO accredited as a lab. So getting the UCAS, take a year and more than a year now to get the data. Getting all the accreditation process for regulatory, so we can get the lab ISO accredited. So when we do the data, it will have the confidence of the regulatory systems. And looking at the trial now is to discussing with MHRA really to register the trial from now on. So when we finish, it will be trial, MHRA knows about it, and the lab is ISO accredited. So it will shouldn't be repeated again. It just get the regulatory approval from the outset. So I think what we try to do is a platform technology for multiple tests with a single collection. Try to do, there is a scientific program to know where they're coming from. And the third thing, an external validation studies to make sure that what we say stands independently and get all the regulatory approval in parallel rather than doing them in sequence. I'm grateful to many people, to many funders, a couple of program grants and many project grants and fellowships, etc. And this is the work of many people, and few of them in Oxford. Here you recognize the names, 3 or 4 in Oxford, Shiraz, Stefan, Yanmi. So you have a few people from here too. So currently, usually, so this is the current group doing it, usually between 2025, and those are the senior academic, which help really in the scientific program. Thank you.
Thank you very much, George. That was just fantastic. Now I'm going to open this. So I'm hoping we're going to have lots of questions. We've got quite a bit of time for questions. So I'm going to keep an eye on the screen as well, but I'll open it up. Has anyone got some questions? David.
You'd say with lung cancer, because one would imagine that breath is much better. Maybe there's been quite a lot of work done with that.
Yes, it could be lung cancer, and it makes sense, of course, because lung. But the reason really, lung cancer, there is a company, Owlstone, they're doing lung cancer. There's no point to repeat other people's work. So, and the other thing, I stick to GI cancer because that's my job. So I can find patient easily. Absolutely, lung cancer is an obvious one.
Bruno.
Thank you very much. Bariatric surgeons, and in bariatrics, thanks to an operation called sleep gastrectomy, we have created a perfect acid reflux storm. And in the Western world, we got lots of concern of all these patients, and I'm talking of millions, who have had sleep and reflux, and in a way we don't know what to do because of the risk of progression towards bladder dysplasia cancer. The same thing is not seen, apparently, in the Asian population. So clearly raising lots of questions. Genetics may be first. So I wonder if how you have looked at genetic in this amazing study of yours.
Can you? I think people online can't always hear the question. So Bruno's asked a question with reference to bariatric surgery about the genetics and volatile compounds.
So the system approach study will give us a good question for this one, but I'm not sure it's just a genetic or a microbiome change between the Far East and the West. So we are currently running 3 studies, one in Korea, one in Hong Kong, and sitting one in India. And in those studies, we will be looking at the difference in the microbiome, a small population, metabonomics to see whether they're different or not. So I don't know exactly the answer because we're not looking at genetics between Far East and the West, but we're looking at the microbiome change and we're looking at the metabonomic change. So I don't know the answer exactly, but we will know the difference maybe in a couple of years' time.
So we got in the online audience, Peter McCulloch has a question. Peter, if you can ask.
Sorry, I was unmuted. George, nice to see you again.
Thank you, Peter.
This is hugely meticulous and groundbreaking work. And you've clearly taken this a long, long way. My question is about the prevalence problem. Because in order to, all of your studies, as I understand it, are in patients who already have a diagnosis of cancer. But the GP's problem is patients who don't have a diagnosis, and the prevalence of cancer amongst them, even early cancer, is going to be much lower. So you may be faced with the same problem that happened in the HIV epidemic, where tests which look very good in the laboratory or in studies in patients who we knew had HIV turned out to have huge problems when exposed to a low prevalence population, and people lost their jobs and so on because they were labeled as HIV positive when they weren't. And there is also a potential resource problem if you then have to do follow-up tests to sort out the multiple false positives you will get for each true positive in a low prevalence population. I'm sure you've thought about this. Maybe your statisticians can give you some modeling answers. What do you think?
Yeah, very good question. So all the validation study, the external validation study, will happen with people without knowing the diagnosis.
So nobody knew whether they had cancer or not?
No.
Oh, that wasn't clear, excuse me.
Yeah, absolutely. So you're absolutely, and that is why I keep saying if the tests stand. So all the external validation study will be, all the blind validation will happen for people without knowing the diagnosis. It may be if I just take your question a bit further to say, well, all those people with symptoms, but no knowing diagnosis. The question which we did not look at, asymptomatic population, because this will need really, if we're going to look at asymptomatic population, the number of patients we need is around 150,000 patients. And this is just another level of complexity. So I can reasonably confident we have a good design for symptomatic population without knowing the diagnosis, but we are not addressing asymptomatic population for screening because it's just beyond the capability of a lab now.
Okay, thank you very much. That raises a whole different set of questions, but I'll stop there.
Absolutely. Thank you.
So I'm still looking out for hands on there. Can I ask a question, George? Hugh Barr, who you remember, and
yes,
many of the older members will remember him from Oxford days. He did quite a lot of research and always said you could smell cancer. Was he smelling the same things that you're now measuring?
I don't know, but he examined a couple of my PhD students. He passed them, so presumably he was happy about the work. I think he used a spectrometry rather than spectroscopy rather than a spectrometry. So he was using a different technology than the one we are using, but he was happy what we do.
I mean, just to follow up with that, of course, well, you showed a picture of dogs there, and in urology, they've used dogs for diagnosing, bladder cancer and so on. And obviously, their sense of smell is incredibly good.
You're absolutely right, but it's very difficult to get a governance structure around the dogs. Is that true? Because we thought about it. And because everybody is saying the same, and they're saying, how can you quantify it? How can you get governance around it? Actually, in Amsterdam, there is a video with a dog going to smell C. diff. Yes, you can do this, but how can you governance this?
Richard Owen.
Thanks very much. Just to know what happens after cancer receptor. So I know these methodological signatures are quite short-lived often, but could we use it as a post-operative sense?
So just briefly, the question for the online audience, Richard Owen's asking whether this can be used post-operatively to look for recurrent disease.
Yeah, it's a very good question. Shiraz did a study which she found that some of the markers they change after surgery. But with time, I realized that this is too complex a study because the microbiome significantly changed, and we know the microbiome affected the signal, and it was so complex that I found it needs a program to answer the question. And like anything else in life, you need to have priorities. And I can just double if everything. I said, I'll just take the diagnostic, get it work. Once we get this, like if we prove this, then we'll go to the question really about the post-op. But what is really important for post-op, actually, maybe more applicable, is the symptoms. Is patient with abdominal distension and bacteria overgrowth, all those patients would benefit immensely from some. So there is a PhD student who is working on the symptoms and the volatile, and I think this will work. But the cancer recurrence is a bigger question than I can handle now with all this, with a 30,000 patient going on. But you're right.
Can I ask another question? So you mentioned the smaller group of the early disease. Do you know yet whether this is stage specific in terms of your pickup rates?
Yeah. So I'll answer your question just in the second part. I'm saying we know that we can differentiate between cancer and no cancer. We know from the colorectal study, because it's the bigger number, there is a difference between stages. We put it in the supplement of the paper if you're going to look at it. But we know that we can pick up the early disease because of the field effect. We don't have data can allow us with confidence to answer exactly the question, because the number of the current previous study were in the hundreds. To answer your question, we need the thousands. So future study will hopefully answer this, but I would expect there will be some compound which change with the disease stage, and some might not change. But I can't be more specific than this.
Again, looking for hands. I can't see any hands in the online. Ah, sorry, Nick Simons.
Nice to see you.
What are the logistics around breath testing in terms of how close your patient has to be to your analysis? And is this something that you can envisage people doing in their own home? Is it something you can send through the post? Do they have to be next to the lab or next to the testing equipment, or what's the logistics around that?
Yes.
So Nick's just asked, what are the logistics of the test and how easy to do, and can it be done at home, or do they have to come into the GP or to the hospital?
Yeah. I'm going to say where are we now and where we would like to be. Okay, so currently the test could be done in a place where they can collect the breath and they send the tube. So that taking the test will be in a GP practice, for instance, and the tube will be in a central lab. The lab, I think, needs quite a lot of quality controls. I don't think it will be just a room in every hospital. I think it will be a regional lab. And actually, a lot of the stool tests, actually, the fit test now in a central lab, not just in each hospital. So it'll be a similar way. Collect in the GP and send to a central lab. We are working on a system which will allow us to collect from home. It is doable, but we don't want to do much of work on this until this works. We need to make sure it works before we go into the next step. But if it works, there is a system in design allow us to do that. And actually, there is a lot of companies, like if you think for people doing bacteria overgrowth, they send things for patients at home to collect and send it back. So the model will work. The question really is, will the trial stand or not? Because if the trial stand, there's no point to do that.
David, James?
That's great. Diagnostic. Very well.
So David's question is there a role of this beyond cancer? Will it be able to diagnose other conditions as well?
So we have done a study with AUC, and there is some data in AUC. The question really is where to start. So I have to have one thing and make it work to the end, because if it doesn't work to the end, I'll just go laterally repeating other things. It'll be a bit, I just need a model which works. And that's why I just need this one work. And if this one works, there are two big areas to work on. If you ask me, one is the response to chemo. And the second one, which even better than this really, is the breath for health, what I call it. Because you can get the markers which differentiate for diet and for exercise, a lot of other things. So if you ask me, what will be more impact than this work, will be using it for a marker of how people are healthy, which is doable. And that would be more impact than what I'm saying. Look, at the end of the day, like anything in life, you need to make decision. What's the most impact of the work? But I think just get this done, and then after that, few other options, maybe.
Good. I can't see any more hands either online or in person. If I'm missing a hand, please do shout out. But I can't see any. So in which case, I'll draw this to a close. I think a mark of a good talk is the amount of questions that are being asked. We've had lots of fantastic questions. It's been a wonderful talk, George, and a huge pleasure to have you visit us in Oxford. We have a tradition at the Grand Round that we give presents to the speakers.
Used to this. So.
I know, no, you're very special here, you see. So it gives me great pleasure to give you a tie, which is the University of Oxford tie.
Thank you.
And a book about John Radcliffe. And actually, we've actually brought the author in today as well, because David Cranston, who we met earlier, has written this book. So that's for some reading on the train back.
Thank you.
Can we have a round of applause? Thank you.